Great. Well, it's great to be back. Good to see everyone. We're so delighted to be here. I saw those pictures that Niti put up from Edinburgh. It makes me very happy. I see quite a few people on the call who are able either virtually or in person to take part in the Cleft 2022 activities. And I think that that's a great place to start for today. I mean, one of the key themes that I noticed in that journey from Cleft 2017 in Chennai, and I see Suraj on the call, who was part of that organizing committee, to this one that just happened recently, was that comprehensive cleft care becoming much more center, and the experience of comprehensive cleft care in low and middle income countries becoming a lot more of a central concern of what people are talking about and discussions that are happening in the hallway and some of the panels. And we're delighted today to have someone, a researcher who was able to make several papers and presentations at Cleft 2022, very much in demand, who's willing to come and really excited actually to join us today to talk a little bit more about this idea of what can we learn from psychology, from some of these research approaches that have been there around parents affected by cleft. How can we prepare them for surgery and for other kinds of treatments? So this is a great question. I can tell we've got a good group. And some of the things we were talking about on Twitter and elsewhere was not only is this the concern of the surgeon or the nurse coordinator, but that sense and the open question I'm going to be asking you as you listen to Dr. Zeytinoğlu Saydam today, how can this be applicable to your specialty, into your context? Because all of us have that sense of how do we prepare for patients to move forward, and all of us can learn from this. So I'm delighted today, without further ado, to introduce Dr. Senem. She's an assistant professor of psychology at Özyeğin University in Istanbul, Turkey. She's soon picking up her life and moving across the world. Maybe she'll share a little bit about that, but she's made time this week before this momentous change to join us. She had completed her Ph.D. at Drexel University. She's been involved in couple and family therapy, and she's got quite a few insights about this sense of working with cleft parents to prepare for a successful surgery and a successful journey. So without any other delay, I'll pass the mic over to Dr. Senem. Thank you for joining us this afternoon.
Hi, thank you so much for inviting me. This is really a privilege for me to present here, and I'm very excited. As you said, I'm in the process of moving from Istanbul to Toronto, actually. And this is kind of like a little bit of me time that I get, that I can have, like I can tell you my perspective and learn from your perspectives and from your insights. So this is my little leisure time in the process of like doing boxes and stuff. So I will be talking about, let me share my presentation with you. So I will be talking about preparing patients and families for cleft surgery, and basically the insights that I have gained doing research on cleft, and also seeing patients and families with cleft as well. So I will be talking about some of the studies that I have conducted, both in United States and in Turkey. And I wanted to kind of outline what we can do as psychological help, or as nurses, or as anyone in the team who's invested in doing psychosocial care, what we can do and how we can improve the lives of the families and the patients in this process. So I will start with sharing my insights during the diagnosis period, during birth, if it's a prenatal diagnosis, first 3 months, before first surgery, and during school age, adolescents and couples, and also like with couples. I especially think that like couples work is very important when working with cleft. I don't think that it is very much paid attention to, but I feel like, you know, it really changes the couple's dynamics, and if it doesn't change the couple's dynamics in the positive way, kids suffer, children suffer. So I feel like it's like almost a prevention tool to work with couples in this process. Oh, sorry. I was gonna tell you about my studies. I think I don't have the latest PowerPoint. I apologize for that. I'm gonna tell you about what I have done. Basically, what are the studies that I have conducted, and how did I kind of get into the conclusions that I have gotten up until this point. So, my first study on cleft was my doctoral dissertation. I was born with cleft as well, so I know that it was really, a big part of my life. Like I had to go through multiple surgeries. It definitely impacted me as a person growing up, and it definitely impacted my family dynamics. So I wanted to explore what are the experiences of couples when they're raising a child with cleft. And I was really curious about if there are any differences between prenatal and postnatal groups, and if, there were differences between fathers and mothers. So, and I was really interested in doing qualitative work. So I wanted to interview mothers and fathers separately and then together as a couple, and then, code the data that I have. And that was the study that I did in Philadelphia when I was doing my doctorate, and I recruited my participants from CHOP, Children's Hospital of Philadelphia, with the help of Dr. Kanis Creerant. She was one of my mentors, and I'm gonna of course share the findings with you as well. I incorporated them to my presentation, but then when I came back to Turkey, I wanted to do something a little bit different, because this idea of like NAM treatment was described as a blessing and a curse from like by patients in the United States. They really liked it because it helped them, it gave them control over their child's treatment, but it also like created a lot of hassle, like doctor's appointments and stuff like that. So I wanted to explore the process that families go through up until as after the first surgery, actually. Like what are some of the experiences that they have, again doing qualitative research. And I interviewed them at 4 different points, and I interviewed like 20 parents of 12 children, so both mothers and fathers. In the study that I have done in Philadelphia, I had interviewed 17 parents, 10 who received a prenatal diagnosis and 7 who received a postnatal diagnosis. And then I also wanted to understand the impact of parents' psychological functioning to their children's psychological functioning. So, like parents' worries about cleft, parents' optimism, how do they see cleft, what are some of the struggles that they have been going through when raising their children, what are some of the services that they need and they can't get. So I did a quantitative study on that as well in Turkey, in collected data from 309 caregivers. So that, and then combined with my clinical kind of experience, I want to talk to you about like what I have seen and what I have learned through these studies and through my clinical practice. I worked in the pediatric neurosurgery unit, preparing children and families for surgery for 3 years when I came back to Turkey. And we also did craniofacial surgeries as well. So like I was working with craniofacial anomalies in that department. And then I was also working in a orthodonty unit that was seeing patients with cleft. So I was also seeing patients there. So, okay. When we look at...
Yeah, good.
Just go ahead. I think someone's mic's on, but yeah, just a quick reminder, if you want to keep yourself on mute, we'll have a great chance. You can use the chat to get involved along the way, and then we'll definitely be opening up for full comments once Dr. Senem's presentation is complete. Thanks.
So one of the things that parents told me when I was like interviewing them is that they had to grieve the loss of a perfect child. One of the fathers said, when I received that, this was a prenatal diagnosis. When I received the prenatal diagnosis, I realized that we all have this dream of having a Gerber baby, like this perfect baby. And now we have to make peace with the fact that, we're not going to have a perfect baby, which is, in my opinion, it's a good thing to realize in the beginning, not because the child is going to be born with cleft, is because none of us is perfect. So it was interesting for me to hear that actually from him. And it might even be considered, I don't know if you're familiar with this term, ambiguous loss. So it might even be considered as an ambiguous loss. There is shock, denial, sadness, worry, and self-blame, which is basically anger at oneself when they first hear about the diagnosis. And fathers especially felt that they had to be a support system for the mothers. So I think that's why hearing the father's perspective is very important as well, because they might also silence their own worries because they feel like they need to be there for the mother and not necessarily show their feelings in this process. Concerns were actually different for diagnosis groups. For the prenatal diagnosis families, they were worried about neurological functioning, co-occurring syndromes, appearance, and social stigma, which makes a lot of sense because, they didn't know their baby then. And up until the baby was born, they had this kind of worry that, oh, what if there's something more? What if, you only see cleft in the, 3D ultrasound, but there is something even more serious than that. And for postnatal diagnosis group, of course, the most concerning part was feeding the child, because they had to feed the child right then and there, right? And the surgery, because it was, these were like the most immediate concerns. Prenatal diagnosis obviously gave families more time to prepare practically and emotionally, but they also reported that there is an increased stress and worry during the pregnancy for them. And postnatal diagnosis group parents said that they actually did not prefer, would not have preferred to know the diagnosis prenatally. They said that they would have been too worried, so they wouldn't want to worry themselves during pregnancy, because there was nothing actually that they could do, to change the fact. But practically, what helped the families was that they wanted to learn more about the issue, especially in the prenatal diagnosis group. They had the time to interview different treatment teams. They had the time to figure out the treatment path, preparing financially, buying special equipment needed, like the special feeder bottles. And emotionally, they were feeling more in control. And they said that they were preparing to see a baby with craniofacial anomaly, and they were preparing the family members and dealing with their reactions as well. So there were a lot of preparation going on. They said that using internet as a resource can be a double-edged sword, because obviously knowledge made them feel more in control and put them in contact with, other parents. Internet did that because they were part of, Facebook groups and stuff like that. But they also said that they were worried for a lot of things that they shouldn't have been worried, because there's a lot of information out there that might be inaccurate and incorrect and unrelated as well. Trust in the treatment team is very important, regardless of the time of the diagnosis. That's why, it's important to kind of encourage the families to get the information from the treatment team and to build a good relationship with them. And, one of the things that families said over and over and over again is that the demeanor when delivering the diagnosis is crucial. whether that be a prenatal diagnosis, whether that be a postnatal diagnosis. It's important to deliver the correct diagnosis, first of all, and advise the family to go through further testing if they're in doubt or something. It's important not to be blaming in both diagnosis groups. And mothers especially stated that they felt better when the doctor said that it's not their fault and it is fixable. So those are some of the key points for the treatment team from the findings that I have. Like it really gives them an orientation to this idea of cleft, how the cleft is framed by the treatment team and by the doctor. Obviously, providing information in a calm, collected manner is important. And sometimes written materials is also helpful because they might ask the same questions over and over and over again, and they might not remember. Like, this is a traumatic moment. Diagnosis can be a traumatic moment for the families. So they might not even remember much of the information that they have received from the doctor. You can encourage the families to take notes. And also like give them enough time to process and ask questions. Sometimes what I do, especially with what I used to do with pediatric neurosurgery group, was that I wanted them to kind of like go home, sleep on it, and then call me the next day with further questions if they have any. So for the birth, what was said again over and over and over again was that it is important for the hospital staff to be knowledgeable on the issue of cleft, especially feeding. So like the hospital staff must know how to use the bottles, must know how to feed the child. They need to have the necessary equipment, like the special feeder bottles. And this is such a sensitive topic, so I'm just gonna kind of like put it out there, and everyone can kind of take what they want from it. But it is important not to force the families for pumping and breastfeeding because that may not be possible. I know that there are different ideas out there as if, like it's really beneficial for the baby to have breast milk. And it really is important for especially to prevent, early deaths and stuff like that. But for the families, they felt really inadequate for them, especially the mothers. They felt really inadequate when they couldn't breastfeed and when they were too tired of pumping and breastfeeding. Providing the families with a treatment path is obviously very important. Before the surgery, we also do in Turkey, like NAM is almost a standard procedure. So we do referrals for NAM in Turkey right after the baby is born. So I'm going to talk to you a little bit about, how that impacts the families as well. Are we clear until here? Do you have any questions, or shall we take the questions at the end?
Yeah, we'll take the questions at the end.
Sure. Okay. So first 3 months is really about preparation for the surgery and learning how to feed your child and how to take care of a baby with cleft. It also, especially in Turkey, it is also the time that people go through NAM treatment. And it is a time characterized a lot by social concerns based on the data that I collected in Turkey. So NAM is associated with empowerment based on what the families were talking about, reduced anxiety, changing view of the child. It was seen as a unifier and as an early fixer in the United States as well. But it was also like a necessary evil, parents described it. For example, like one of the mothers said, I feel like I'm the person that is always causing her pain. you know, because I'm trying to put it on to her, and then she's crying and she's obviously uncomfortable, and I don't know if, you know, the babies will remember this or it will be in her unconscious. It will probably be in her unconscious. So there is that worry. But then there is also this kind of help with feeding that parents are very grateful for. You know, they said that yes, there were wounds on her cheeks. One of the mothers said that I had a lot more courage feeding her because Nam was there blocking the holes. And they were saying that, you know, like through the NAM treatment, they could see their child's nose is appearing, and they couldn't see it before. He couldn't breathe through, like the child couldn't breathe through his nose because so he was snoring, and now the snoring was gone. So I mean, just seeing the change is very important for the families. And one of the fathers in the United States said that during the interview, was that I feel like I was reconstructing my child's face, and it gave me a lot of control over what I can do for him, because otherwise I didn't feel like I could do anything for him. The, you know, closing of the gap was very hope producing for the families. One of the fathers said it went down from like 12, the hole went down, the gap went down from 12 millimeters to 6 millimeters, which was a big change for him. There was obviously social concerns. Parents were worried about the other people's reactions. They tried not to show their child to other people because they thought that this appearance is only temporary, so they don't need to be, you know, other people don't need to be seeing their child and making judgments based on the appearance that the child has then. And after the surgery, they said that they could feel the joy again, and they said, you know, like now we feel like we have a child, like now we can celebrate having a child that we couldn't do before. Main reason for surgery is described as improving appearance. One of the fathers said we live in a visual world, so it's very important. Obviously, there are other reasons such as improvement in health, function, and comfort. And most common worries for the families is complications during surgery. The child receiving anesthesia. That's why I think like the anesthesiologist is very important. Like I remember a mother telling me that the anesthesiologist came to the room and picked the child up and like carried her to the operation room at CHOP, and like that still gives me goosebumps, and that still like brings tears to my eyes, because that really meant a lot for the mother as well. Pain after the surgery was very concerning, and of course impact of the process on the child, on the surgery process and the pain. For the children, the most common concern was the IV and the needle. They wanted to know if it's gonna hurt, basically, and they were scared of that. It is important to adjust the expectations for school-age children, adolescents, and families, because they might feel like they're gonna have one surgery and it's gonna be a fix, or they're gonna look, you know, in a certain way. So I think it is important to kind of not show the surgery as a miracle that will occur and that will kind of erase all their worries. One of the findings in the literature has also been that especially adolescents attach a lot of meaning to the surgery, and thinking that it will also improve their like psychological well-being and self-esteem. And you know, and then they realize that after the surgery, if they didn't work on it, the psychological well-being piece and the low self-esteem is still there. Again, trust in the treatment team is very significant in reducing anxiety. I always encourage, I think like it's common practice here, but in Turkey, you know, unfortunately it's not. families must provide information to the children and their siblings, especially after the age of 3 and beyond. But I believe that even like little kids, you gotta tell them, like in very simple terms, giving them what they're gonna go through, about the procedure, like what's gonna happen to them. Let them know that there might be IVs and needles and it might hurt. And they're gonna be, the parents are gonna be there for the children when the IV is like being put on, and they're gonna help them help the child to endure the pain, and maybe they might even come up with some strategies that they can help the child when they are having difficulty, like rocking. I asked the mothers, for example, like leave their undershirt with the children, so that the child can like smell the mother, as she or he is recovering from surgery. Timing is important. So before, like after the age 3, like it's better to tell the children at least 3 days before, so that the child can also process it and ask questions that she or he might have. One of the suggestions that I make when I see children with cleft is that social relationships are very important. So I think the responsibility relies with the families, that they're gonna kind of help their children socialize at a young age, and they're gonna kind of create a environment for them that they can make friends from childhood, that they can rely on, and that they're not going to be they're going to have relationships that they're not going to be judged. At the same time, they should be prepared to answer questions in the way that will kind of prevent people from bullying and increase their comfort level with the issue, with the cleft, and creating resources such as hobbies and things that children and adolescents can define themselves with, other than their appearance or other than the cleft. So that's very important. Like you got to look as parents, I think, all parents need to do this, but you got to look for strengths for the children and build on them, obviously. How am I doing with time?
We are running a bit short, maybe another 3 or 4 minutes of the presentation.
Okay, sure. And including adolescents in the decision-making process is important. Surgery plans understand the differences between adolescents and parents' expectations and wants. Giving adolescents information about the treatment path is important. Adjusting expectations is obviously key, showing before and after pictures, and informing families and adolescents about the post-operative appearance and possible appliances that they might have to wear after the surgery and during the recovery period. Because, obviously, appearance is important mostly for adolescents, and they might know what they're gonna look like in the first months after the surgery. Couples are impacted through this process. Something that I really enjoyed seeing in Turkey is that the relationships became more egalitarian. So, like, because the fathers saw that the mothers were really suffering, and they wanted to help and they wanted to protect their children, so they became a lot more involved in house chores and baby, like caretaking of the baby. I have one father said, before getting married, I never thought that I would be putting my child to sleep or feed my child, but my wife also has her limit, so I had to do it. I know what I'm saying is not nice, but as a man, I never thought I would do this. So for me, it was, exciting to see that this was the change that happened in the relationship. Also, families, couples sometimes felt like they couldn't really share with one another what they're feeling because they have to support the other person. I think it would be helpful to do a couples group, after the prenatal diagnosis would be great, actually, because, it would be one of the preparation tools as well. I am an emotionally focused therapy trainer, so we have a couples group called Hold Me Tight, and it's one of my dreams actually to run the group with cleft parents, like parents who have children with cleft. So and it gives them kind of this idea to like share with one another what they're feeling, what they're experiencing, and how they're gonna keep their relationship alive when they are fighting this battle after the baby is born and before, as they're preparing. So here are my references, and thank you for listening. If you have any questions or comments, I am very, very eager to hear them.
Thank you, Dr. Senem. Fantastic.
Okay.
So we've got off a lot to cover there in terms of moving through a bit of a journey from those families who were able to get a diagnosis pre-birth to, and I think you'll catch up a little bit in the chat now that you're not presenting, that there was definitely some conversation about how common that was in many of the contexts for people in this environment who are joining us today. All the way through to working with older children and how to put them at ease for this idea, like you've had yourself, of multiple surgeries along the way. So my question again for everyone, as to remind you of what Niti's instruction was, please feel free to post a comment or a question in the chat. You can also signal if you'd like to ask a question directly or make a comment directly, then you can put your hand up and we can acknowledge you. And that's great if you can turn on your camera to do that so we can see each other. And then always just please acknowledge your context. We know that we're all the way around the world looking around this group. So each context will be quite different, but we're eager to hear your perspectives. And I think, again, bringing in this theme of you, whatever your specialty is in the cleft treatment process, how do you see some of these psychological insights playing out in your role, and what is your role, do you feel like, in preparing parents to have a successful, or even children to have a successful treatment journey? So we see a comment here from Naomi saying that in her own context, this idea where you have seen in your research in Turkey inspiring examples of couples coming together, rallying around this idea of a cleft, but also and I personally have met many families where that's been a cause of major marital discord or even separation, that the pressure really makes it less likely for parents to move through. I'm not sure, Naomi, where are you, what's your context? What have you seen? And you can just either post that or not, but Senem, can you comment a little bit more? Have you seen the alternate also, that pressure of an unexpected diagnosis leading to difficulty for couples?
Right. So let me make something clear. I think it's important to highlight that, is that when I interviewed the couples during the up until the first surgery, after the first surgery, it was like in the beginning. So I don't know if this like rallying around the cleft actually stayed that way, and if the roles were changed permanently. And then when I was interviewing the couples in the United States, the oldest child was around 4. So in the first, 4 years, or the first months of the diagnosis, what I have heard from the parents was that if they had a previous problem, if they had issues communicating, if they had issues coming together, if they couldn't rely on one another, then yes, cleft made it worse.
Mm.
But after, before, but on the other hand, when, like they already had a kind of like a good relationship, they were able to like put the cleft in the back burner and, come together and do things, together as well. So I think it's important to screen couples for pre-existing struggles. I think, like, for example, dyadic assessment scale is a great scale for that because it also gives you a cutoff score as to if the couple is distressed or not. And I saw, like, my sample was very small, so I didn't really talk about this, but what I saw was couples who were receiving the postnatal diagnosis were more stressed, relationally stressed than the prenatal diagnosis. So obviously that tells me from from a very small sample is that existing stressors and postnatal diagnosis can be risk factors for negative impact on couples relationship.
Thank you. Suraj, I'm going to call on you. You have quite a bit of experience both in treating families in more of an urban context like Chennai and also in some rural districts. How would you describe, I mean, obviously there'll be different exceptions, but how would you describe overall, what are some of the psychological stressors that are different for families from a very rural context in terms of dealing with a cleft diagnosis?
You're asking me, Hugh?
Yes. What are your observations? Obviously, it's a great question. So I want to know what occurs to you, and if you were contrasting the psychological stress in general for parents from a rural context as opposed to an urban context.
I think there are two aspects which have, whether the families dismiss the problem or, how they react to the problem is something which we need to understand. And people do not, go in touch with their inner self, especially in the rural communities. So they come up with information around them and then try to identify who is the problem and try to fix the problem. So it becomes a very big thing. The attention does not go to the child, it goes to the family member to pinpoint who is the problem, what happened. So the child suffers more than the parents in the first 24 to 48 hours because the reassurance has not provided. So there are two extremes to it. So it's a very difficult, and there is something called survival rate in some of the low and middle income countries, whether a child has a chance to survive that period or not. That also goes with the amount of reassurance, whoever is the primary caregiver who is providing, and then in the state of mind of the family. So there are multiple things. So I just wanted to know from her experience whether she has got any perspectives on educated and not so educated families, and especially in the rural communities.
Thanks, Suraj. Senem, do you have a comment? I saw you nodding.
I agree with it was interesting. I remember one family, for example, the father learned about the diagnosis and fainted. So like nobody was necessarily this is postnatal diagnosis. The child was born and the mother was trying to feed the child, and then everybody had to tend to the father because he was so distraught. So this is exactly why I feel we need to come up with tools that can be used by all the family members, even when a professional is not present on site. So it can be I'm not going to go into that, but then what really calms the families down is a lot of validation and a lot of reflection based on their experience. Just letting them know that you understand, and it, of course, it makes a lot of sense to you that they're having this reaction. And as you validate them, I think one of the things that I would refrain from doing is to kind of like help them, distract them, or help them like feel like, you know, it's not something to be worried about, their worst problems. Of course, it's fixable, it's not their fault, but obviously they have the right to feel like, you know, their child is in danger, or, you know, like they have to endure something that they haven't expected before. So a lot of validation and a lot of reflection of their feelings usually help.
Thank you, Dr. Senem. So not necessarily minimizing what the family's going through and telling them all will be fine, no worries, but that sense of actually really walking with them through, you know, some legitimate fears, even if their response is not necessarily the one that they're going to stay with, but challenging that right away and saying, oh no, you know, you're making too much of this is maybe not from your research is not the best approach. Thank you.
And there are obviously like other clinical tools that can be used, like you know, trauma-based approaches, breathing techniques. Like there are many clinical tools that need to be like that can be used as well. But I think this is the kind of like the demeanor that the professional need to have.
Thank you. So we had a few more comments from the Ugandan context about how marital discord or breakdown is much more common than strengthening in those contexts. And the idea of this, you know, the particular pressure on fathers in some ways, you know, where the blame, quote unquote, might be, you know, for more strongly felt or experienced by mothers, that fathers, you know, feel that they have some, you know, some difficulty in moving forward. So the comment came up earlier, this idea of parent support groups or connecting parents to others who've been through that. Either from the group or Dr. Senem, do you have any idea about specifically about, you know, fathers talking to fathers about their how to be helpful during this process?
Right. I don't know how is it in your context. In my context, it used to be really hard to do groups. Now it's a lot easier because we have Zoom and we can meet online. But I think like fathers, especially in countries where, you know, gender equality is, you know, not very apparent, I think like men feel comfortable talking to men, right? And they want to like kind of get their comfort from their people who feel like they're sharing the common destiny with. So I think that would be a great way to kind of help the fathers as well. Another thing is, I think the doctor's position is very important here, because as at least in my culture, like there is a certain level of respect for the doctor. So if the doctor makes something clear, they're more likely to believe it. So this blame, especially like when the event is framed by the doctor and the treatment team over and over again, it kind of like gets into the family's minds in that way.
Thank you. So there is a special role, you know, in understanding the culture. You know, if surgeons, for example, are really held up in that hierarchy, then the words that they speak directly to the families can have more weight than even the most compassionate nurse coordinator or anything else, whether we think that's fair or not, but that's something you've observed. Very helpful. That brings us to another point Michael helpfully commented, and this is again for the group. All of us, you know, interact with families who've had a very suboptimal or negative experience along the way. Hopefully not, you know, often with their own care, but either, you know, was operated on by someone who didn't give them a good experience. What about the specific ways of preparing older children or even adults for surgery when they've had a really not a great experience of their first repair, and they need to be revised, or there needs to be something else that's gone on, or maybe they had just had a really miserable treatment in the hospital the first time around. And I know that medical Mobile Surgery International that Michael's talking about, that's one of their key focuses. So what do you think about that sense of someone who's been through all this process and it hasn't gone well, now they're coming back for treatment? What are some of the psychological insights that you think we could be thinking about, and this is for the whole group, when you have a re-repair or something that's gone wrong the first time?
Well, I want to kind of first understand the impact that it had on the patient. Like, was it a traumatic impact? How worried is this person? How does she or he cope with the worry? How does that impact his or her view of the surgery and the treatment team as of now? If it's a traumatic experience, then I have like trauma-based techniques that I work with the client on like overcoming that trauma. And I would kind of like talk about the worst part of the experience and, introduce techniques to self-soothe. Also do, I don't know if you're familiar with the technique EMDR, like with the patient. So I work from that perspective.
Thanks, Senem. And maybe you could type in the chat the name of that treatment. I think as we've seen a little bit in the chat also from Man in Myanmar and Suraj in Chennai, the sense of compassion, and really rather than minimizing, the really negative experience that someone would have maybe had the first time, especially if things haven't gone well, to really engaging with it in terms of saying, recognizing that it would have been traumatic to have a really bad experience of cleft treatment to start off, and starting from there, as opposed to just saying, oh, don't worry, it'll be fine this time, we'll fix you up, no problem. It sounds like that sense of spending a little bit of time journeying with them. And one of the questions that Suraj brought up is, you mentioned this idea of assessment, and this is for the whole group. How do you assess what the experience of a family has been, and how well they are going to be potentially equipped to deal with some of this? Like, what are some strategies that teams can use in sort of identifying which patients or families would need potentially more support and more of this journeying?
Right.
We recognize that all the resources and people's time is limited. So how do we make the most of the time that we have in preparing families well for treatment?
Well, okay, but that's based on my experience, I use Tier 3 survey developed by American Craniofacial Association. I think it's a great tool. I also use revised dyadic adjustment scale. It gives you an idea about how the couple is coping. I give PTSD scale to see if they have any signs and symptoms of trauma. And because it can change with every family. Like, I had a client where she was really regretful about the surgeon that she chose, and she was feeling like it was her fault that her son did not get the appearance that she wanted him to get, basically. So we worked with that in therapy, like when we're working with trauma. So for everyone,
so to just interrupt, this you would recommend from your research some sense of both a conversation with prospective parents as well as potentially some sort of tools. Now, I know not every team in different countries would have access to some of these tools at this point, but you recommend that some sort of tool-based approach to that interview can really be helpful in guiding the team and deciding, how best to support this family.
I'm happy to send you the tools that I use, and you don't have to give them the tools, because sometimes I can't give them the tools because they don't know how to read and write, or it wasn't translated in my language, so I had to do the translation. But you can also take from the questions, like I would ask, what is the worst part of cleft? How does it impact your life? How does it impact, your couple's relationship? How does it impact your child, you think? So like having these questions, I can also send you the questions that I ask for the interview, like the research interviews. I feel like they also give a lot of information about what the family is going through. And it also assesses for the kind of vulnerabilities that the families might have. You don't have to
Yeah, that's very interesting. So the idea that even just looking at the tools ourselves as professionals, even if we're not in a position to be able to implement them, can help us understand some of the thinking behind them and what questions we might ask, even if it's not in a research-oriented sort of technical way of administering a tool. That's very helpful.
It kind of orients you.
So my question to the team, when we have a few minutes left, who on your team do you feel has primary responsibility for doing this kind of assessment and guiding the team about vulnerabilities? Who on your team would be in a position to know whether this family from a rural situation like Suraj was talking about, or from a more educated city situation, what is their vulnerability? What is some of their fears? How can we help them prepare for this so that it's a good outcome for everyone? And I see Dr. Zucker has commented in the chat, confidence in treatment team is important. It is that a generic team or an individual person that can make a difference. So again, even if your whole team is not fully aware of all these things, even one person who's compassionate, according to Ron's long experience, can really make a difference. That's what a family can hold on to and remember through this treatment. Really helpful point, Ron.
Yeah.
Anyone else with a question or a comment? And I'll keep trying to monitor the chat as I talk here. So we have Panawan mentioning, just the importance that if someone does feel like it is their responsibility or have that interaction with parents before treatment begins, just how important it is for that person to bring the other team member into the loop and to make sure that people are sensitized to this. And I think we saw that in the chat a few times along, that it's easy to say, oh yes, we're a very compassionate team, etc., and that can be true. And yet in the midst of just, numbers of treatments needing to happen, to be scheduled and through their day, it can be easy to forget, that even though we experience cleft every day or regularly, that for this family, it is a huge event and a singular event. And sometimes they're the only person in their whole sphere that they know who's been through this. And so keeping that front and center can be a really helpful strategy.
It's also from just two things that I want to add with regards to that. First, I think you're absolutely right. It doesn't have to be a psychologist. I think anyone, anyone who is willing to kind of apply these can go a long way. And also this kind of comforting way, comforting the families, I derive a lot from emotionally focused therapy, and that really helps with the crisis management as well.
Thank you. Yeah, that reminder that for a family, I mean, obviously many of us experience this regularly, but that the diagnosis is a crisis. It can be the most significant challenge that the family has encountered, ever, or at least in some time. Even if it is something that seems fairly straightforward for many of us in terms of our own practice and way forward. And thanks for Joshua for your comment. Everyone on the team must be sensitized and be aware of what should be done when and where. Yeah, that thing. And Emily, remembering, to say how sorry we are to the family, that even though we know there are great outcomes and a bright future ahead, starting at that point of just empathizing with the family can be a really interesting way of gaining that kind of confidence that allow them to invest in a treatment plan. Very helpful. Niti, we're coming to the end of our hour. It's almost time to thank Dr. Senem. Can you pull back up? What else do we have in store? So a quick reminder, this has been recorded. And so very soon you'll be able to see this on the YouTube channel. So if you do have people on your team who thinks, this is something we need to talk about, would you consider showing this recording, or at least part of it, Dr. Senem's presentation perhaps, to your team at your next meeting, to pass this along, to say, hey, we need to have a conversation about this. How is our whole team, as some of the comments have said, how equipped is our whole team to be aware of some of these things? And we've got Grace commenting here, agreeing with Ronald, and just that idea of how everyone needs to be involved in that. That can be such a helpful reminder for us. So for each of us on the call today, what's the idea that's the most compelling for you? Maybe you want to look into some of these tools that Dr. Senem was talking about. Maybe you want to have a meeting to talk a little bit more about some of the more traumatic experiences that families have had, and how that interrupts, or how addressing that effectively can really lead to better outcomes. and then what's your next step? So we've offered a couple in terms of the video, in terms of you can watch. Also, if you were involved with Cleft 2022, Dr. Senem had a few different papers that were presented, and you can get a little bit more of the research, an 8-minute chunk of what was there that you can look at as well. So we're delighted that you all made time to join us today. Our hour is up. Please stay tuned. We did do an evaluation of our journal reading club that happened before Cleft 2022, and we're reflecting on that. We stay tuned for next steps in there. Many of you have received email from us about the conference, the Solutions for Comprehensive Cleft Care conference that's going to be coming up in January. One of the themes that we will be looking at is weaving psychosocial care through every step of a patient's or a family's journey. So we'll be drawing on Dr. Senem's insights for that conference as well. And in the meantime, please do stay tuned. You can get in touch with us at info@cleftcircle.org if you have an idea for a topic that we haven't touched upon sufficiently, or if you have some research that you'd like to talk to us about. We're always listening. So thanks very much for today. Have a great morning, afternoon, or evening, and see you next time.